Modern medicine has made childbirth safer than it has ever been in human history. It's truly an incredible success story. But kind of hidden inside all that success is this one persistent risk, a danger that's created by the very process of pregnancy itself. So today, we're going to dive into the science of maternal aspiration, what it is, why it happens, and the really elegant strategies doctors use to keep it from happening. First up, we're going to see just how massive this medical triumph has been. Then we'll get into the physics of what I'm calling the pregnancy squeeze. From there, we'll zero in on the specific danger of aspiration, what doctors do if it becomes an emergency, and most importantly, all the proactive steps they take to make sure that emergency almost never happens.
Okay, so let's start with the big picture, because it is a truly monumental achievement in healthcare.
Think about that. Within just a single generation, one of the most dangerous moments in a person's life has become overwhelmingly safe. Now, this didn't happen by accident. Nope, it was a result of a really systematic, multi-layered approach to patient safety. This success really comes from a whole cocktail of pharmacology, new techniques, and just plain smart policies. You've got much better anesthesia, like epidurals, which let patients stay awake. We're using medications to control stomach acid. The anesthesia techniques themselves have gotten way faster and safer, and even simple enforced rules like nothing by mouth before a procedure add yet another crucial layer of protection.
But despite all this success, pregnancy itself throws a wrench in the works. It creates this unique physical and hormonal challenge that medicine has to constantly, and I mean constantly, account for. Let's take a look at the mechanics. It really is just a squeeze. It all comes down to simple physics, right? The growing uterus puts a ton of pressure on the stomach, squishing it and pushing everything up. This physical pressure alone creates a super high-risk situation for acid reflux. And this physical pressure combines with what is basically a physiological perfect storm. So first, the hormone progesterone actually relaxes the valve at the top of the stomach, which weakens the barrier. Second, the stomach acid stays really high. And third, the stomach just takes a lot longer to empty its contents. So you've got a weaker barrier, more acid, and all of it is sticking around for longer. It's a real recipe for trouble. So this brings us to the core risk we're talking about today. What happens when that reflux escapes the stomach and goes the wrong way? Not up the esophagus, but down into the lungs. Well, the result is something called aspiration pneumonitis. Now, this is not your typical pneumonia caused by bacteria or a virus. It's a chemical burn to the lungs caused by stomach acid. And what's absolutely wild is the threshold for damage is shockingly low. It only takes about 25 milliliters. That's less than a single fluid ounce of highly acidic fluid to cause a severe lung injury. Now, when the lungs get injured like this, it immediately messes with the body's oxygen supply. This leads to two related but different conditions: hypoxemia and hypoxia. They sound super similar, I know, but telling them apart is absolutely critical in an emergency. So what do you think? Which one happens first? The answer is hypoxemia. The little clue is right there in the name. That suffix, emia, means in the blood. So hypoxemia is the first thing that happens. You get low oxygen in the blood. And when the blood can't deliver enough oxygen, well, the body's tissues start to starve. That second stage, that's hypoxia. It's a domino effect, and doctors are basically racing to stop it at that very first domino, in the blood. So if the absolute worst happens and aspiration occurs, what does that race against the clock actually look like? Well, the response has to be immediate and incredibly precise. Priority number 1, clear the airway. A flexible scope with a suction tube goes in to clear out the upper airway right away. If any larger food particles went down, a more rigid scope is used to physically go in and get them out. It is all about minimizing the amount of time that damaging stuff spends inside the lungs. After the airways clear, the management continues. The patient stays intubated until the medical team is 100% certain their airway is stable. Antibiotics are given to prevent a secondary bacterial infection from setting up shop in the already injured lung tissue. And for patients who aren't intubated, a CPAP machine is used to help support their oxygen levels and fight that hypoxemia we were just talking about. Okay, so while it's critical to know the emergency response, the real success story of modern obstetrics is making sure that response is almost never needed. It's all about proactive prevention, stopping the problem at the source.
So the first line of defense is medication, with a kind of three-pronged attack on stomach acid. You've got antacids, which give immediate relief by neutralizing the acid that's already there. For longer-term control, H2 receptor antagonists reduce the signals telling the stomach to make acid. And then you have the heavy hitters, the proton pump inhibitors, or PPIs, which work to shut down the little pumps that produce acid in the first place. And beyond the meds, other measures add even more layers of safety. A drug like metoclopramide can be used to help the stomach empty out faster. There's the Sellick maneuver, which is a physical technique where an assistant applies pressure to the throat during anesthesia induction to help block the esophagus. And, this one's interesting, allowing clear liquids during labor actually helps promote faster emptying, which reduces the total amount of stuff in the stomach to begin with.
You know, the story of managing maternal aspiration is just a perfect example of modern medical progress. It's not always about heroic last-minute interventions. It's about deeply understanding a risk and then systematically, piece by piece, dismantling it before it can ever cause harm. And this leaves us with a really critical question. As we get better and better at conquering the obvious dangers, what are the next subtle, hidden risks that we need to find and solve? Thanks for tuning in.
All right, welcome. Today we're jumping right into one of the most high-stakes scenarios in all of medicine, and that's managing the airway of a pregnant patient. You know, the changes a body goes through during pregnancy create some really unique challenges, and being prepared, it's just not negotiable. So let's break down exactly what makes this so tough, and more importantly, how to manage it.
So, what's the deal? I mean, what really makes a pregnant patient's airway one of the most difficult to manage? You might think it's some kind of rare complication, but the answer is actually much more fundamental. It's the normal changes, the things that are supposed to happen during pregnancy, that create this challenge.
And that's why we call this a uniquely difficult airway. It's not just another procedure. This is a situation that really demands a whole different mindset, a totally different approach. Why? Because the patient's body has been fundamentally changed by the pregnancy itself. Yeah, when you get right down to it, it all comes back to these huge anatomical and physiological shifts that pregnancy triggers. I'm talking about expected changes that directly affect everything from the shape of the airway itself all the way down to a patient's oxygen reserves. And that's what creates the very specific problems we have to be ready to solve.
Okay, so let's get into the nitty-gritty. How do these physical changes actually affect what you do at the bedside? Let's turn this from anatomy into action, and we'll start with one of the most obvious physical hurdles you'll face.
So here's the first big one, breast enlargement. And look, it might seem kind of straightforward, right? But it has a huge mechanical impact on one of the most critical procedures you have to perform.
And this is a perfect example of a problem and its solution. It's a simple physics issue, really. The enlarged breast can literally get in the way of a standard laryngoscope handle, making it super difficult, sometimes even impossible, to get the tube in. So the key is just thinking ahead. You have a stubby handle ready to go, and that simple swap, just having the right piece of equipment on hand, can literally be the difference between success and a crisis.
And that idea of thinking ahead brings us to the core strategy here, proactive preparation. The best way to handle this isn't to react to problems as they pop up, it's to anticipate them before they even start. And this whole approach is built on what we can call 5 pillars of prevention.
So what are these 5 pillars? Well, first, using neuroaxial techniques, things like spinals or epidurals, to try and avoid general anesthesia in the first place. Second, being really strict about fasting guidelines to lower that risk of aspiration. Third, and this is a big one, optimal patient positioning. Fourth, making sure you get really thorough pre-oxygenation. And finally, number 5, always being ready for a rapid sequence intubation, or SRI, using cricoid pressure.
Okay, so all 5 of those are absolutely vital. But for now, we're going to zero in on patient positioning. Why? Because it's such a critical hands-on technique that you can master, and it can just dramatically boost your chances of success. Honestly, getting this one part right from the get-go can change the entire game.
And here's the trick. It boils down to one simple, super memorable rule. The earlobe should be in line with the sternum. That's it. That little visual cue is your guide. If you can get that alignment right, you're setting yourself up for a much smoother intubation.
This technique has a name. It's called ramping, and it's pretty literal. You're basically building a ramp with pillows or blankets to lift up the patient's head and shoulders, all to get those airway axes lined up perfectly. This becomes even more crucial for obese patients, where extra tissue can make getting that alignment a real challenge.
But let's be real. Even with the best preparation in the world, things can still go wrong. So you have to have a plan for the unexpected.
What do you do when, despite everything you've done, you just can't get the tube in? This is where a clear, pre-planned protocol becomes an absolute lifeline.
Because in a crisis, your most important tool isn't some fancy piece of equipment. It's your plan. It's having a clear, step-by-step guideline that the whole team knows cold. It gets rid of the guesswork and lets everyone act calmly and decisively when, every single second counts. So, what does that guideline look like? It's pretty straightforward. Okay, first attempt at laryngoscopy fails. What do? You try one more time but switch to a different blade. Now, what if that second attempt also fails? That's when you stop. The very next move is to call for help. Get another colleague in there to try. This whole structure is designed to stop one person from making repeated, failing attempts.
And really, that brings us to the key takeaway of all this. When it comes to patient safety and obstetric airway management, it's not about one single magic bullet. It's about a powerful combination. You need that proactive prep, getting the positioning right, having the stubby handle, all of it. And you need a crystal clear, well-rehearsed plan for when things go sideways.
So we've walked through the technical steps, the protocols, the what to do, but that leaves us with one last, really critical question. You can have the best protocol on the planet, memorized perfectly, but when that crisis hits, is your team's communication just as sharp? Is it as effective as your clinical skills? Because that right there, that's the human element that makes or breaks everything.
Headaches after giving birth are super common, but they are definitely not all created equal. Today, we're doing a deep dive into one very specific and often pretty severe type of postpartum headache. Honestly, understanding what it is can make all the difference in getting the right help and fast, so let's get right into it. Okay, so here's our game plan. First, we're going to survey the whole landscape of postpartum headaches. Then, we'll zoom way in on a specific type, called PDPH, what it is, what it feels like, who's most likely to get it, and most importantly, how to treat it.
All right, let's start at the beginning. Getting a headache in the days or even weeks after having a baby is something a lot of new parents complain about, but it's really important to figure out why it's happening.
So basically, postpartum headaches fall into two main buckets. On one side, you have primary headaches. These are usually tied to things you might expect, like all those wild hormonal changes. But then, on the other side, we have secondary headaches. And these are kind of like a red flag that something else is going on. And as you're about to see, that something else is often connected to the anesthesia used during labor.
And this is a really big deal. I mean, just look at this number. A whopping 2/3 of all those secondary postpartum headaches are linked back to anesthesia. That's a huge connection, and it brings us right to the specific headache we're going to unpack today.
Okay, let's get to the heart of it. We're talking about something called a post-dural puncture headache, or for short, PDPH. This isn't just some random headache. It has a very specific cause, and it's directly linked to really common procedures like an epidural or a spinal block. So what is it exactly? Well, in medical terms, PDPH is a headache that shows up within 5 days of a spinal procedure, and it's caused by a leak of cerebrospinal fluid. That's the fluid that cushions your brain and spinal cord through a tiny, accidental hole in the protective membrane around them, which is called the dura mater.
The best way to think about it is like a slow leak in a tire, right? The tire still has air, but that tiny loss of pressure completely changes how it works. It's the same idea here. When even a little bit of that cerebrospinal fluid leaks out, the pressure inside your skull drops. And that drop in pressure is what causes such an intense headache.
This slide just lays out the whole chain reaction perfectly. It all starts with that tiny dural puncture. That little hole lets the cerebrospinal fluid leak out. The leak causes a drop in pressure around the brain. And that pressure drop, boom, triggers that very severe and very specific kind of headache. You can see the straight line from cause to effect.
Okay, so we get what causes it. But what does a PDPH actually feel like? Well, the symptoms are super distinct, and they're really the biggest clues for getting a proper diagnosis.
The main event, of course, is a severe headache, but it's often got some sidekicks. We're talking things like a really stiff neck, or even weird changes in your hearing, like things might sound muffled, or you might get a ringing in your ears.
But this, right here, this is the absolute #1 hallmark sign of a PDPH. Its defining feature is its relationship with your posture. The headache comes on almost instantly when you sit or stand up, and then it disappears just as fast within about a minute when you lie down flat.
This positional nature, this on-off switch with your posture, is what doctors call an orthostatic headache. And you can imagine why that's so debilitating for a new parent who's trying to, sit up and feed a baby. It's the most classic symptom, but just remember, doctors are also going to look at those other signs we mentioned to see the whole picture.
So the big question is, right, why do some people get this while others don't? Well, let's take a look at the known risk factors that can make someone a bit more susceptible. You can pretty much group the risks into 3 main areas. First, there are patient factors, like being under 40 or having a vaginal delivery. Second, there are procedural factors, like if it takes multiple tries to place the epidural. And finally, the technique itself is a huge one. This can include the specific type of needle used, its size, and even the method used to find the right spot. All of these can play a role.
Okay, so after all that, here's the really good news. This condition is very treatable. So let's walk through the different ways to get relief and fix the actual problem. Treatment generally follows 2 paths. The first step is usually non-invasive and conservative. We're talking rest, staying hydrated, maybe some caffeine. But if that doesn't do the trick, there are more invasive procedures designed to go right to the source of the problem and literally seal the leak.
And when it comes to those more direct procedures, one stands out as the absolute gold standard, the epidural blood patch. It's actually a pretty clever solution. A small amount of your own blood is drawn, and then it's carefully injected back into the epidural space, right near the original puncture. That blood then clots and forms a natural seal, a patch, over the hole, stopping the leak for good.
So, what does the road to recovery look like? Well, it's really reassuring to know that a lot of these headaches will actually go away on their own, but it can be a tough couple of weeks. For those who need relief faster, the blood patch is, hands down, the most effective treatment. It doesn't just mask the symptoms, it fixes the leak, which means a much quicker return to feeling like yourself again.
See, knowing all of this is so empowering. It lets you ask really specific, informed questions. For instance, if you get a terrible headache after your epidural, you can actually say to your care team, hey, this gets so much worse when I sit up. Could this be a PDPH? Knowing what to look for and what to ask is truly the first step in advocating for your own health and getting the care you need right when you need it the most.
So, you've probably heard about epidurals, right? They're super common for pain relief during childbirth. But have you ever wondered what's actually happening with your nerves? That's what we're going to get into today. We're going to take a closer look at something called neuroaxial anesthesia. Think epidurals, spinal blocks, and really break down the potential nerve-related issues and, more importantly, how your medical team works to keep you safe through it all.
Okay, first things first, let's make sure we're all on the same page with the terminology. When we say neuroaxial anesthesia, that's kind of the official, big-picture term for things like epidurals and spinal blocks. The whole idea is actually pretty simple. It's all about putting medication right up close to the nerves in your spinal cord. And what that does is numb the lower part of your body.
Now, I gotta say this right up front, and it's super important. This is a really, really safe procedure. Seriously, the whole point of this explainer isn't to scare anyone. Not at all. It's just about pulling back the curtain a little bit. You know? We're going to look at the kinds of things that could happen, from the really common and minor stuff to the super, super rare things that your doctors and nurses are total pros at preventing and handling.
All right, so here's how we're going to break it all down. First, we'll talk about the common side effects, the stuff that's temporary. Then we'll get into some other nerve complications. After that, we'll touch on the risks that are rare but serious. And to wrap it all up, we'll look at the big picture and talk about just how safe this all is.
Okay, let's dive into our first section, the common temporary side effects. So this is the stuff that's most likely to happen, and the key word here is temporary. These things are usually pretty manageable and tend to clear up all by themselves.
So the number one most common nerve issue you might hear about has this really fancy name, meralgia paresthetica. I know, it sounds like a mouthful, but what it is actually pretty simple. There's this nerve in your thigh, the lateral femoral cutaneous nerve, and it can get a little bit affected. All this means is you might feel some temporary numbness or a tingly sensation on the outside of your thigh. And here's the most important part. It's just about sensation. There's no muscle weakness involved, and it almost always just goes away on its own. No treatment needed.
All right, another really common, and again, temporary thing has to do with your bladder. You know how normally your nerves send a signal to your brain saying, hey, time to go? Well, neuroaxial anesthesia can kind of press the mute button on those signals for a little while. This can mean you might have trouble peeing, which is called urinary retention. And that's exactly why the medical team keeps a close eye on things for a few hours afterward, just to make sure all those signals come back online like they're supposed to.
Okay, moving on. Let's talk about some other nerve complications. Now, what's really interesting about these is that they're often not caused by the anesthesia medicine itself. Instead, it's more about physical pressure on certain nerves.
You might see a list like this one mentioning different types of nerve palsies. And some of these names might even sound familiar, like the sciatic nerve or the femoral nerve. Basically, a palsy just means you could have some weakness or numbness in the leg or foot. But the real question is, what's actually causing it? And this is the key, right here. The main culprit usually isn't the medication. It's pressure. Just prolonged pressure on a nerve. This can happen because of the baby's position, or maybe from being in one position for a really long time during labor. The nerve just gets squished for a bit, and that can cause these temporary problems.
So what do we do about it? Well, the management strategies are actually pretty straightforward, which is great news. The medical team will try to help you change positions often, just to move those pressure points around. They also use the smallest amount of anesthetic that still works, so you can actually feel if something new is happening. And of course, just speaking up and telling your team if you feel any new numbness or weakness is absolutely crucial.
All right, now we're going to shift gears and talk about the risks that are much more rare, but also more serious. And remember, the reason we're talking about these is so you can understand all the things your medical team is actively working to prevent.
But before we do, I really need to emphasize this point. What we're about to cover is extremely rare, especially for expecting mothers who are usually young and healthy. Think of these as the worst case, 1 in a million scenarios that have tons of safety checks in place to stop them from ever happening.
Generally, these serious issues fall into one of 4 buckets. You've got traumatic injury, which is from the needle, infective, like getting an infection, ischemic, which has to do with blood supply, and chemical, which would be a bad reaction to the medication. So let's see what the pros do to prevent these.
When it comes to infections, prevention is literally everything. That's why putting in an epidural is such a sterile process. I mean, they clean the area, use sterile drapes, gloves, the whole 9 yards. It's all designed to make sure no nasty germs get in, which is why things like meningitis or an abscess are so incredibly rare.
Another one of these rare risks is called an epidural hematoma. Basically, this is a collection of blood that forms in that same epidural space. And the problem is, if it gets bigger, it can start putting a lot of pressure on the nerves, or even on the spinal cord itself. So you might be wondering, if this is a potential risk, why is it sometimes hard to spot?
Well, here's the tricky part. The epidural is working so well at blocking pain that it can also block the feeling of pressure that a hematoma might cause. And that's the danger, right? If it keeps growing, without anyone knowing, it can turn into a big problem by squishing the spinal cord.
And because this is considered a true neurosurgical emergency, prevention is absolutely key. That's why, before they even start, doctors will check your blood, specifically your platelet count, to see how well it clots. It's all about assessing the risk for any bleeding problems ahead of time.
And this quote really says it all. When we're talking about ischemic injury, that's damage from a lack of blood flow. It says it's rare in this group because, well, expecting moms usually don't have artery disease, and doctors are super aggressive about treating any drop in blood pressure right away. It's just another layer of safety.
Okay, so we've gone through a lot of detail. Let's zoom out now and get to the big picture. What are the main things you should really walk away with?
So let's tie this all together. Here are your key takeaways. Number 1, neuroaxial anesthesia is an incredibly safe procedure. That's the main headline. Yes, complications can happen, but they are absolutely not the norm. Most of the common stuff, it's temporary and it just gets better by itself. And maybe most importantly, your medical team is trained for all of this. They have systems and plans to prevent, watch for, and handle any of these risks.
And this brings us to a final thought. This isn't about being scared. It's about being informed. So how can knowing about these risks actually make you a more empowered and even safer patient? When you know what's possible, you know what to communicate to your doctors and nurses. It's definitely something worth thinking about.
All right, let's get right into it. Picture this. You're in the recovery room. Your patient just had a perfect epidural for her delivery, but now she's telling you about some weird numbness in her leg. What's going through your mind? What's on your differential? You know, it's that kind of thinking, that post-block vigilance, that really makes a great provider. So today we're going to break down all the key neurologic complications of neuraxial anesthesia. We're talking spinals and epidurals, so you are ready for anything.
Here's how we're going to tackle this. We've got 5 main sections. We'll start with the stuff you'll see most often, the peripheral nerve palsies. Then we'll get into some bigger system-level issues. Look at a true can't-miss emergency,
touch on some rare but critical risks, and then we'll wrap it all up with a rapid-fire review designed to stick in your brain for boards.
Okay, first up, peripheral nerve palsies. Seriously, these are by far the most common neurologic problems you're going to hear about or get tested on, so you've got to have a solid handle on them.
Now this looks like a big laundry list of things that can go wrong, mostly due to positioning or nerve compression. But don't get overwhelmed. For your exams, and honestly for most of your clinical practice, we're just going to zero in on a couple of the real key players here.
And this is number 1 with a bullet, meralgia paresthetica. If you remember one palsy, make it this one. The nerve is the lateral femoral cutaneous nerve. And the absolute key, the thing that gives it away, is that it's a sensory-only problem. Your patient's going to complain about numbness or tingling on the outside of their thigh, but their muscle strength, totally fine. And here's the best part. It almost always gets better on its own. Your job is just to know what it is and reassure the patient.
So what about other palsies, like a peroneal nerve palsy from pressure up by the knee? Well, our whole game plan here is about being proactive. First, use a low concentration of local anesthetic. We want a sensory block, not a dense motor block where the patient can't move at all. Second, be obsessive about repositioning your patients. And third, if they say anything about new numbness or weakness, you've got to listen and change their position right away.
Okay, so we've covered the peripheral nerves. Now let's kind of zoom out and look at some broader, system-level issues, focusing on the bladder and the central nervous system itself.
Postpartum bladder dysfunction? This is a big one. Neuroaxial blocks, especially spinals, can basically stun the nerves that tell your bladder it's time to go. The result is urinary retention. So here's your high-yield clinical takeaway. If your patient hasn't been able to urinate for a few hours after the procedure, it's time to start looking into it. And of course, always be a good clinician. Make sure you've ruled out other causes before you blame the block.
All right, CNS lesions. Thankfully, these are really rare, but when they happen, they're devastating. We can basically bucket them into 4 causes: trauma from the needle, infection from bacteria, ischemia from a lack of blood flow, or a chemical injury. And the clinical pearl here, this is non-negotiable. Strict, almost religious aseptic technique is your #1 defense against causing an infective lesion.
Okay, I need you to really tune in for this next section. We're going to shift our tone a bit because this is one of the most feared complications in our entire field. We're talking about hematomas. This is not a watch and wait situation. This is a true emergency.
Let me be crystal clear. When a collection of blood, a hematoma, forms in that tiny space around the spinal cord and starts pressing on those nerves, you are in a race against time. This is an immediate neurosurgical emergency. The patient needs surgery to relieve that pressure, or they could face permanent paralysis.
So, what are the testable, must-know pearls? First, always check your patient's coagulation status, especially their platelets, before a needle goes anywhere near their spine. Second, and this is a classic boards trap, a perfectly working epidural can completely hide the #1 symptom of a growing hematoma, which is severe back pain. The analgesia is so good they don't feel it. You have to rely on tracking their motor and sensory function like a hawk.
All right, let's round out our tour of the scary but rare complications by looking at infections and vascular injuries. Again, low frequency but incredibly high stakes.
We just talked about aseptic technique, right? Well, this is exactly why. Any little break in your sterile field can introduce bacteria and lead to one of 2 disasters: an epidural abscess, which is a pocket of pus pressing on the cord, or meningitis, a full-blown infection of the lining of the spinal cord and brain.
And what about vascular injury? Well, the biggest fear is spinal cord ischemia, cutting off blood flow to the cord. The good news? It's super rare in our healthy OB patients because we're so aggressive about treating low blood pressure. The risk is way higher in elderly patients with existing vascular problems, or really in anyone who has a long period of significant hypotension.
And anytime we talk about the spinal cord's blood supply, there is one name you absolutely, positively have to know for your exams, and that is the artery of Adam-Kvyat. Think of it as the main plumbing line for the lower part of the spinal cord. So why is this one artery so famous? Look at this. The entire front 2/3 of the spinal cord, that's the part that controls all your motor function, your ability to move, is supplied by that one single anterior spinal artery. The back third gets blood from 2 posterior arteries. This anatomical setup makes the cord incredibly vulnerable. If something happens to that one artery, you're in big trouble.
Whew! Okay, we have covered a lot of ground. So let's boil it all down into a high-yield rapid review. This is the part you'll want to screenshot or jot down for your last-minute studying before the big exam.
All right, let's do this. Lightning round. Meralgia paresthetica?
Most common involves the lateral femoral cutaneous nerve, and it's sensory only. Epidural hematoma, a neurosurgical emergency where great pain control can actually hide the problem. Spinal cord ischemia, just remember that vulnerable anterior two-thirds of the cord and its single blood supply, the artery of Adamkiewicz. And finally, bladder dysfunction. If they haven't peed in a few hours, it's time to investigate.
So there you have it. We've gone over the risks, the red flags, and the must-know facts. The final step is turning all that knowledge into confidence. So take a look at this list and ask yourself, which one of these do you feel the most ready to spot early and manage correctly? Because at the end of the day, that's what keeps our patients safe.
Today, we're jumping right into the topic of preterm labor. You know, it's this intense race against the clock, a really complex medical challenge where every single hour counts. We're going to break down all of it, the key definitions, the super high-stakes risks, and the critical responses that doctors and nurses use to navigate this whole situation.
Okay, so let's dive in with the basic definition. What even is preterm labor? Well, it's any labor that kicks off before 37 completed weeks of pregnancy. And that 37-week mark, it isn't just some random number. It's basically the developmental finish line, especially for one of the most vital organ systems a newborn needs to survive out in the world, their lungs.
And that actually brings us to a really key question. For a premature baby, just being able to breathe is the first huge hurdle. And this ability depends almost entirely on this stuff called pulmonary surfactant. It's what keeps the tiny little air sacs in the lungs from collapsing. So, where does this life-saving substance actually come from?
And the answer is type 2 alveolar cells. These are incredible, highly specialized cells that just kick into gear right around 24 to 26 weeks of gestation. This timeline is so fundamental to the whole idea of fetal viability. It's that point where survival outside the womb starts to become a real fighting chance, all thanks to these cells starting to produce that surfactant. So what happens when a baby is born before all these systems are fully up and running? Well, the stakes are incredibly high. Let's take a look at the specific, really serious complications a preterm fetus is up against.
We're going to focus on 3 major risks. First, there's umbilical cord compression, which can cut off oxygen. Second, intracranial hemorrhage, which is bleeding in the brain. And third, idiopathic respiratory distress syndrome, which, you guessed it, ties directly back to what we were just talking about with surfactant.
This quote really paints a picture of the physical challenge here. A full-term baby's skull bones have had time to harden and get ready for the pressures of birth. But a preemie's skull, it's soft, it's not fully calcified, and that makes it incredibly vulnerable to injury during delivery. So how do you protect a structure that's so fragile? It is all about control. The goal during a vaginal delivery is to make it as gentle as humanly possible. We're talking a slow, controlled delivery of the head, with as little pushing from the mother as they can manage. And things like a spinal or an epidural, they aren't just for pain relief here. They're a critical tool to completely relax the pelvic floor, which reduces pressure on the baby's head. Let's circle back to the lungs for a second. So while that surfactant production starts way back around 24 weeks, the levels aren't really high enough for easy, independent breathing until after 35 weeks. That's a huge gap. A long time where a preterm infant is at a really high risk for what we call idiopathic respiratory distress syndrome, or IRDS.
Fortunately, there's a really powerful way to intervene. By giving the mother a type of steroid called glucocorticoids, like betamethasone, doctors can actually speed up the fetus's lung maturity. But it's not an instant fix. It needs a crucial window of 24 to 48 hours to actually work. This is that race against time we talked about. Trying to delay labor is often all about buying enough time for these steroids to do their job.
Okay, so we've seen the problem, we get the stakes, now let's switch gears and look at the medical response. How is preterm labor diagnosed, and what can actually be done ahead of time to prevent it for people who are at risk?
You know, a diagnosis like this needs concrete evidence. It can't just be a feeling. And one of the key clinical signs is the frequency of contractions. A pattern of 4 documented uterine contractions in just 20 minutes, or 8 in an hour, is a major red flag that true preterm labor might be happening.
Of course, clinicians are looking at the whole picture, not just one thing. This also includes being in that 20 to 37-week window and seeing actual physical changes to the cervix, like dilation or effacement. That's when the cervix thins out. They can even use an ultrasound to look for fetal breathing movements, because if those are absent, it can be a really strong predictor that delivery is about to happen.
For patients who have a history of preterm birth or other risk factors, prevention is absolutely key. 2 main strategies are a prophylactic cervical cerclage,
which is basically a stitch that helps keep the cervix closed, and progesterone therapy, which can help support and maintain the pregnancy.
So, here's the crucial part. Once preterm labor is confirmed, the clock is officially ticking. The goal shifts from trying to prevent it to trying to delay it. So let's look at the toolkit clinicians have to try and hit the pause button on delivery.
The go-to medications for suppressing labor are called tocolytics, and while there are a few options out there, the current thinking points to calcium channel blockers, something like nifedipine, as the first-line treatment, and that's mainly because they tend to have fewer serious side effects compared to the other options.
And this table right here just brilliantly illustrates how complex managing a patient is. It's not just about stopping contractions. Each one of these tocolytic drugs interacts with the body differently and has huge implications for anesthesia if a C-section becomes necessary. For instance, if a patient is on magnesium sulfate, they're going to have decreased muscle tone, making them way more sensitive to muscle relaxants. The entire medical team has to be perfectly in sync.
But sometimes, despite everyone's best efforts, delivery is just unavoidable. Or it might even become the safest option. So how does the team navigate the very specific challenges of a preterm delivery? A C-section might be performed for a few key reasons. If the fetus is showing any signs of distress, if there's severe intrauterine growth restriction, or if labor just stalls out and isn't progressing, a surgical delivery might be the only way to make sure the baby is safe.
Another common issue is when the amniotic sac breaks early. And to confirm this, clinicians use a super simple but really effective tool, nitrazine paper. See, amniotic fluid is alkaline, but the normal environment of the vagina is acidic. So if the membranes have ruptured, that paper will turn a very distinct blue, giving a quick, clear answer.
And how this situation gets managed all comes down to a critical tipping point, 34 weeks. Before 34 weeks, the risks of being born so early are huge, so the goal is to delay, using antibiotics to ward off infection. But after 34 weeks, the baby's lungs are so much more mature. The whole risk-reward calculation flips. At that point, the danger of infection becomes a bigger threat than the risk of prematurity, and delivery is the safer option.
Which really leaves us with the central dilemma of managing preterm labor, doesn't it? It's a constant, high-stakes balancing act. Every single decision is this careful weighing of risks and benefits, trying to give the fetus as much time as possible to develop while protecting both the mother and the baby from immediate dangers like infection. It is a massive challenge that requires incredible skill, timing, and teamwork.
All right, today we're going to get into some of the really fascinating ways a pregnancy can go off the beaten path, specifically looking at two scenarios that are really well understood: what happens when a baby is breech, and what the body goes through when it's carrying multiples. You know, you always hear about the textbook pregnancy, but the truth is, a lot of pregnancies have their own unique story. So what happens when things take a little detour? Well, as we're about to see, these aren't scary, unknown problems. They're actually well-understood situations that modern medicine is absolutely ready for.
Okay, first up, breech presentation. It might sound like a complicated medical term, but it's actually pretty simple. It's all about which way the baby is pointing before birth. It's not necessarily a problem, but it does mean taking a different path to delivery, one that requires a very specific game plan. So what is breech? Well, simply put, most babies get into a head-down position, ready for birth. But with breech, the baby is positioned with their bottom or feet pointing down towards the birth canal instead. It's a fairly common thing to see, especially in the last few weeks of pregnancy. And what's really interesting is that breech isn't just one position. There are actually three main types, each a little different. You've got frank breech, where the baby's legs are folded up straight against their body. Then there's complete breech, where the baby looks like it's sitting cross-legged. And finally, incomplete, where one or both feet are pointing down. Knowing the exact type is super important, because it helps doctors plan the absolute safest way to deliver. So why all the special attention? Well, it's because this position can come with some potential complications. For instance, there's a risk of umbilical cord prolapse, which is when the cord can slip down ahead of the baby and get squeezed, cutting off oxygen. Recognizing serious risks like this is the #1 step to managing them and making sure everyone ends up safe and sound. And this just shows you how prepared the medical teams are. They have very specific plans in place. Depending on the exact situation, they might use analgesia for pain relief, or they have specialized anesthesia techniques ready to go if a vaginal breech delivery is the plan. It's all about having the right tools for the job. Okay, let's switch gears. We're moving from the baby's position to the number of babies. We're talking about multiple gestation, twins, triplets, you name it. And as you can imagine, this presents a whole new set of challenges, and often, though not always, means a C-section is planned from the get-go.
The definition here is pretty straightforward, right? Multiple gestation just means carrying more than one fetus. But while the idea is simple, the effect it has on the human body is, well, it's anything but. And this is really the key. Think about all the huge changes the body goes through in a normal pregnancy. Now with multiples, you basically crank the volume on all of them up to 11. The body's response isn't just bigger, it's amplified on a whole other level. And that leads us to the truly incredible ways the body responds. I mean, how does it even begin to adapt to the demand of growing more than one human at the same time? The numbers behind it are kind of mind-blowing. Let's start with plasma volume. In a single pregnancy, it already increases a ton. But with twins, the body adds an extra 750 milliliters on top of that. To put that in perspective, that's like adding a full-sized bottle of wine's worth of extra fluid into your circulatory system. And all that extra fluid means one thing. The heart has to work so much harder. You can see it right here. Cardiac output, that's how much blood the heart is pumping every minute, is a full 20% greater in a multiple gestation. That is a massive jump in the heart's workload. So how does the body pull off that 20% boost? It's pretty clever, actually. It uses a two-pronged attack. First, the heart pumps more blood with every single beat. That's the stroke volume, up 15%. And it also just beats a little bit faster, about a 3.5% higher heart rate. Both of those things together get the job done. But it's not just the heart working overtime. Think about it. With a much larger uterus pushing up from below, the lungs just have less room to breathe. This means their functional residual capacity, which is basically the safety reserve of air left in your lungs after you exhale, it shrinks. So what does that shrinking reserve actually mean for the mother? It's critical. It means that during any procedure, her oxygen levels can drop, and drop fast, even if she's been given extra oxygen beforehand. This is something the anesthesiology team is watching like a hawk and has a very careful plan for. So when you put all these intense changes together, it's easy to see why managing a pregnancy with multiples is all about being proactive. It means much closer monitoring for both mom and the babies, and yeah, it often leads to a higher rate of C-sections just to make sure delivery is as safe as it can possibly be. So really, the bottom line is this. Whether we're talking about a baby who's decided to face the other way or a mother carrying more than one, a deep understanding of these variations is the absolute cornerstone of safe and effective modern medicine. I love this quote because it really gets to the heart of it all. We don't see these things as just random, scary complications anymore. They are understood challenges, and for every single one, there are proven, well-established strategies to manage them. And that kind of leaves us with one final thought to chew on. When you look at the incredible level of detail, the physiological knowledge, and the meticulous planning that goes into these situations, you just have to ask yourself, how does all of this showcase the amazing power and precision of modern medicine? All right, let's dive into a really critical topic for every single anesthesia provider: hypertensive disorders in pregnancy. This explainer is all about giving you the most essential, testable info you need for your board exams and, of course, for your clinical practice. So first off, why is this such a big deal? Well, get this, up to 10% of all pregnancies in the US are complicated by hypertension. That makes it the most common medical issue in pregnancy and a leading cause of some really serious problems for both mom and baby. So here's our game plan. We're going to start with the basic definitions, then jump into the diagnosis and the crazy pathophysiology of preeclampsia. After that, we'll cover the essential drugs, our anesthetic management, and then we'll wrap it all up with a rapid review of the most important takeaways. Okay, let's get started. Section 1, definitions. You know getting the diagnosis right is the absolute foundation for your entire management plan, so we've got to start here. We've got two main conditions to distinguish. First, there's chronic hypertension. This is when the patient already had high blood pressure before getting pregnant, or it shows up before that 20-week mark. Then you've got gestational hypertension, which pops up after 20 weeks. The key things to remember are the timing and the fact that with gestational hypertension, you don't have proteinuria, and it usually goes away after delivery. Section 2, the preeclampsia diagnosis. Now we're getting to the one we as anesthesia providers are most concerned about: preeclampsia. And let me be clear, this is not just high blood pressure. It's a whole different and way more dangerous multi-system syndrome. So what is it? The classic definition of preeclampsia is a new onset of hypertension and proteinuria after 20 weeks. And here's the kicker. We still don't really know what causes it. Because of that, the only definitive cure is delivery of the baby and the placenta. Now, when you're at the bedside, you're often looking for a classic triad of signs. The first one, no surprise here, is hypertension. That's the foundation of the whole thing. The second part of that triad is edema. And it's super important to understand this isn't just swollen ankles. We're talking about generalized systemic edema. And for us, that screams airway. It can cause major laryngeal swelling, which can make for a very, very difficult airway. And the third piece of the puzzle is proteinuria. This is our big clue that the disease is now hitting the kidneys, causing them to leak protein into the urine. So you put them all together, hypertension, generalized edema, and proteinuria, and that's your classic triad. But this thing can get worse. So what happens when this whole process escalates and starts to seriously mess with the central nervous system to the point where the patient actually has a seizure? Well, that's what we call eclampsia. It's pretty simple. It's preeclampsia plus seizures. This is a massive, life-threatening obstetric emergency, and it needs immediate action. Okay, Section 3, pathophysiology. To really manage these patients well, you have to think of preeclampsia as a disease that attacks multiple systems. So let's just go through it system by system from our anesthesia point of view. So in the central nervous system, you're going to see things like a severe headache or visual disturbances. The patient might seem really jumpy or hyperexcitable, and they'll have hyperreflexia, those super brisk reflexes. And this is a high-yield point, guys. The disease itself causes hyperreflexia, but our main treatment, magnesium, will cause hyporeflexia. You've got to know that difference. From a cardio and pulmonary standpoint, these patients are in a hyperdynamic state with a high cardiac index. And all that generalized edema we talked about puts them at a huge risk for pulmonary edema, especially if we get too aggressive with fluids. Of course, that same edema leads to that dangerous laryngeal swelling, which is a major airway risk. Hematologically, the big one we worry about is thrombocytopenia, low platelets, because that directly affects whether or not it's safe to do a spinal or epidural. In the placenta, the disease messes with blood flow and cranks up the risk of a placental abruption, which is a true surgical emergency. Section 4, pharmacology. So now that we kind of get what's going wrong in the body, let's talk about how we treat it. We're going to focus on the two main classes of drugs you absolutely have to know: antihypertensives and magnesium sulfate. For that really high blood pressure, IV hydralazine is a very common first choice, often followed by IV labetalol. Now, a really key clinical point is about nifedipine. It's a potent tocolytic, meaning it relaxes the uterus, which can seriously increase the risk of postpartum hemorrhage. And sodium nitroprusside? We save that for the absolute worst-case scenarios because of the risk of cyanide toxicity. Now for magnesium sulfate, our #1 anticonvulsant. The therapeutic level we're shooting for is somewhere between 4 and 9. So how do we know if we've pushed it too far? Well, the first clinical sign of toxicity is the loss of those deep tendon reflexes, which usually happens around 10 to 12. That's exactly why checking reflexes is so important. You got to think of magnesium as a double-edged sword. On the good side, it's a fantastic anticonvulsant, and it's a vasodilator, which can help blood flow. But on the bad side, it causes that same uterine relaxation, or tocolysis, that we saw with nifedipine, which can mean a longer labor and more bleeding. And for us in anesthesia, the most important point is that it causes muscle weakness and makes the patient way more sensitive to neuromuscular blocking agents. All right, Section 5, anesthetic management. Let's take all this information and apply it directly to the decisions we have to make. This is probably one of the most common and critical questions you'll face. Your preeclamptic patient is in a ton of pain. She wants an epidural. You check her labs. Is it a go or a no-go? The #1 concern is the risk of an epidural hematoma if the patient has low platelets. Now, every hospital might be a little different, but a really common and highly testable threshold is a platelet count below 100,000. For many, that's an absolute no-go for a spinal or epidural. Okay, so let's imagine regional is out. We have to do a general anesthetic. Based on everything we've just talked about, what's your #1 concern as you get ready to manage that air wire? The primary risk is airway obstruction from that severe laryngeal edema. You have to go into it anticipating a difficult airway every single time. That means having the difficult airway cart right there and planning to use a smaller endotracheal tube like a 6.0. And on top of all that, don't forget she's on a magnesium infusion, which puts her at risk for respiratory depression. Whew, we have covered a lot. Let's wrap this up with a super quick, rapid-fire review of the absolute highest yield points. This is the stuff you've got to have locked down for your exams and for safe practice.
Let's do it. Key takeaways: the classic triad, hypertension, generalized edema, and proteinuria. Magnesium's therapeutic range, 4 to 9. The first sign of mag toxicity, loss of reflexes at 10 to 12. Regional anesthesia, usually a no-go if platelets are under 100,000. And with general anesthesia, your priority is to anticipate a difficult airway and grab a smaller ETT. So let's end with this final thought. You walk into the room. Your patient needs an urgent C-section. Her blood pressure is through the roof at 175/112. Her platelets are 90,000, and you can see she's got a difficult airway. What do? Putting all this information together to make a safe, fast decision in that moment, well, that's the ultimate test, isn't it? Today, we're diving into some of the most critical, high-stakes situations in all of medicine: obstetric emergencies. We're talking about those moments where everything can change in an instant and the lives of both a mother and her child hang in the balance. So, what really happens when a pregnancy suddenly veers off course and becomes a life or death situation? Well, it's not just one thing. It's an immediate, all-hands-on-deck medical response, a true race against time where there is absolutely no room for error. And that's exactly what we're going to get into. We'll look at some of the specific complications that can pop up and the incredibly tough, decisive actions doctors and nurses have to take to navigate these crises. First up is a condition with a name that really says it all. It's an acronym, sure, but it's also pretty much a cry for help. It's called HELP syndrome, and it's this dangerous cascade of problems that can escalate with, frankly, terrifying speed. Now, officially, HELP syndrome is seen as a really severe form of preeclampsia. But the truth is, we still don't fully understand why it happens. What we do know for sure, though, is that it is profoundly dangerous. So what does HELP actually stand for? Well, the H is for hemolysis, which is when red blood cells start breaking down. The EL is for elevated liver enzymes, which is a major red flag that the liver is being damaged. And LP stands for low platelets. And that's critical, because platelets are what your body needs to form clots and stop bleeding. And this whole thing happens fast. It can quickly lead to something called DIC. That's disseminated intravascular coagulation, which means blood clots start forming all over the body where they shouldn't be. All of this can lead to complete liver and kidney failure. It's a total full-body crisis. This brings us to a really stark and, frankly, brutal reality. There is only one effective treatment, and that is immediate delivery. It doesn't matter how far along the pregnancy is. It's an extreme step, but it's taken because the only other option is to risk the lives of both the mother and the baby. All right, so moving on from issues like HELP, there's another kind of systemic threat that can creep in: infection. A big one to watch out for is called chorioamnionitis. Basically, it's a serious infection of the membranes that surround the fetus. But the real danger is that it can spread to the placenta, the uterus, the umbilical cord, and even to the fetus itself. Now, you might look at the numbers and think, okay, it only complicates about 1 to 2% of pregnancies. But here's the kicker. Its presence dramatically increases the risk of another huge emergency: postpartum hemorrhage. So this one relatively rare infection can be a major warning sign for a much more common and deadly problem. Okay, so we've looked at these system-wide failures, we've looked at infections, but what about the most immediate, the most visceral threat that can happen right there in the middle of delivery? Well, that threat is hemorrhage. We're talking about catastrophic blood loss that instantly turns the delivery room into an intense race against time. Now, two of the main culprits for severe bleeding before birth have to do with the placenta. With placenta previa, the placenta is actually blocking the baby's way out. And with placental abruption, it starts to tear away from the uterine wall way too early. Both are incredibly dangerous situations. But placental abruption has this extra hidden danger. You see, unlike with previa, where the bleeding is usually obvious, with an abruption,
all of that bleeding can be happening on the inside, totally concealed within the uterus. And the amount of blood we're talking about is just staggering. You can have up to 4,000 milliliters. That's 4 liters of blood trapped inside. To put that in perspective, that's nearly the entire blood volume of an average adult. This means the medical team might have no idea how bad the blood loss is until the mother is already deep in shock.
Hemorrhage can also be caused by a uterine rupture, which is a literal tear in the wall of the uterus. The signs here can be tricky. Yeah, there might be bleeding and severe pain, but you could also see shoulder pain from the internal bleeding. And then, the most terrifying sign of all, the baby's heartbeat just disappears.
And then there's this last one. It's incredibly rare, but just devastating. It's called vasa previa. And what's happening here is that the baby's own blood vessels are running across the membranes right in the path of delivery, completely unprotected by the placenta or the umbilical cord.
The danger here is just instantaneous and catastrophic. When the water breaks, those fragile exposed vessels can tear open, and that, as the medical texts put it, may lead to exsanguination of the fetus, a rapid, fatal loss of blood for the baby. Okay, so with all of these absolutely devastating scenarios on the table, how in the world do medical teams manage the crisis? This is where the anesthesiologist plays an absolutely critical, life-saving role. And you can see here just how much the underlying problem changes the game plan. So, if a patient has HELLP syndrome, her platelet count might be so low that an epidural is just too risky. If she's hemorrhaging, her blood volume is so low that regional anesthesia is also out. In those cases, you have to go with general anesthesia for an emergency C-section, and you have to be so careful with your drug choice, using something like ketamine or etomidate that won't drop her blood pressure even more.
Ultimately, trying to manage a massive hemorrhage is an all-out effort. It means aggressively pumping in fluids and blood, activating massive transfusion protocols, and all the while using invasive monitors to get a second-by-second picture of what's happening inside the mother's body.
It really just leaves you with this one question to think about. In the middle of a crisis, with 2 lives literally on the line, how do these medical teams make such complex, split-second decisions knowing that there is absolutely zero margin for error? It's truly extraordinary. All right, today we are diving into obstetric emergencies. These are the high-stakes, low-frequency events that you absolutely have to be ready for. We've put this explainer together as a super high-yield review, perfect for both your board prep and for when you're out in clinical practice. So let's get right into it.
So here's our game plan. We're going to start with the #1 cause of postpartum hemorrhage, that's uterine atony, and then we'll look at problems with the placenta itself. After that, we're diving into the big systemic crises, DIC, thromboembolism, and the one that everyone kind of fears, amniotic fluid embolism. And don't worry, we'll wrap it all up with a rapid review to really make sure the key takeaways stick.
Okay, first up, uterine atony. If you're going to know one cause of postpartum hemorrhage, this is it. It's the big one. And the problem is actually pretty simple, but man, is it dangerous. After delivery, the uterus is supposed to clamp down hard, right? But with atony, it just doesn't. It stays soft and boggy, and that means all those blood vessels where the placenta used to be are just wide open and pouring out blood. I want you to think of this slide as your mental checklist. The second your patient walks in with any of these risk factors, your antenna should be up for uterine atony. A mom who's had multiple babies, too much amniotic fluid, a really big baby, or an infection like chorea amniotis, these are all major red flags. They're basically telling you, hey, be ready for this. Okay, listen up, because this is about as high yield as it gets for your exams. The treatment for atony is a step-by-step algorithm. It all starts with uterine massage, sure, but the very first drug you are always going to give is oxytocin. Always. If that doesn't do the trick, you escalate to methergine. Still no good, then you go to carboprost, which you probably know as Hemabate. Invasive stuff like a uterine tamponade or even a hysterectomy, that's the absolute last resort when the meds just aren't working. So what if the uterus is contracting just fine, but your patient is still bleeding? Well, that brings us to our next big cause of hemorrhage, problems with the placenta itself. We're talking about things like a retained placenta or something much, much scarier, placenta accreta. Now, here we've got 2 totally different problems. But, and this is pretty cool, they share the same anesthetic fix. So with a retained placenta, the OB needs to get in there and get it out, but the uterus is clamped down too tight. The solution? A little bit of IV nitroglycerin. It relaxes the uterus just enough for them to work. And the same exact logic applies if the uterus inverts, turns inside out. You have to relax it to put it back where it belongs, and a quick shot of nitro does the job perfectly. And now we get to a really, really dangerous condition, placenta accreta. The problem is simple but incredibly severe. See, normally there's the special layer, the decidua, that lets the placenta peel away cleanly after birth. Think of it like Velcro. Well, in accreta, that layer is just gone. The placenta grows directly into the uterine muscle. So trying to remove it isn't like peeling off Velcro, it's like trying to rip off something that's been super glued to the wall. The result is just catastrophic bleeding. And you gotta know, this isn't just one thing. It's a whole spectrum of how deep that invasion goes. Here's a great little mnemonic for your boards. Accreta adheres, increta invades, and percreta perforates. That last one, pericreta, is the absolute worst-case scenario. We're talking the placenta can actually grow straight through the uterine wall and attach to other organs, like the bladder. Just to really put this into perspective, look at that number, 2 to 5 liters of potential blood loss. That is, quite literally, the patient's entire blood volume. If accreta is even suspected, the plan is usually a scheduled C-section that goes straight into a hysterectomy, leaving the placenta right where it is to avoid that massive initial bleed. And for you, as the anesthesia provider, you have to be ready for a massive, massive transfusion. Okay, let's switch gears and talk about DIC, or disseminated intravascular coagulation. This one is a truly terrifying paradox. Basically, the body's clotting system just goes completely haywire. It starts forming thousands of tiny clots everywhere, in all the small vessels. This uses up all the clotting factors and platelets, which, you guessed it, then results in uncontrollable bleeding from everywhere else. You're clotting and bleeding at the same time? So what kicks off DIC in a pregnant patient? Well, a lot of the other emergencies we're talking about today. A placental abruption is a classic trigger. So is an amniotic fluid embolism, which we're getting to in a bit. And that's why the absolute #1 priority in managing DIC is to figure out what's causing it and treat that underlying problem. This table right here is pure gold for your exams. You have to know this cold, and it tells the whole story of what's happening in DIC. Your fibrinogen and platelets, they're rock bottom because they're being consumed to make all those little clots. Your PT and PTT, they're getting longer and longer because all the other clotting factors are used up too. And your fibrin degradation products are sky high because the body is desperately trying and failing to break down all the clots. It is the classic picture of total consumption. And here it is, the absolute bottom line, non-negotiable rule for us as anesthesia providers. Let me be crystal clear. Neuroaxial techniques, we're talking spinals and epidurals, are absolutely contraindicated in a patient with DIC. With no platelets or clotting factors, the risk of causing a bleed near the spinal cord, an epidural hematoma, is just way too high. It's not worth it. These patients have to get general anesthesia, period. All right, next up, let's talk about thromboembolism. You see, pregnancy itself creates this high-risk state for blood clots. And because of that, a pulmonary embolism becomes a leading and often tragically silent cause of maternal death. So why is the risk so high? Well, it's perfectly explained by the classic Virchow's triad. Remember that from school? Pregnancy literally checks all 3 boxes. You've got venous stasis because that big uterus is pressing down on the pelvic veins. You have the potential for vascular damage during the delivery itself. And most importantly, pregnancy is a hypercoagulable state by its very nature. It's designed that way to stop mom from bleeding out during delivery. It's just a perfect storm for forming a clot. The signs of a PE are pretty classic. That sudden shortness of breath, a sense of anxiety or doom, a racing heart. And just like with DIC, if your patient is on anticoagulants for a clot and they need a C-section, the anesthetic choice is clear. Neuroaxial is just too risky. It's got to be general anesthesia, and you need to be prepared for the fact that their airway might be more prone to bleeding. And now, for our 5th and final emergency before the big review, amniotic fluid embolism, or AFE. This is the very definition of a low-frequency, high-acuity event. It's rare, it's totally unpredictable, and it is often catastrophic. We're talking about an incredibly high mortality rate. This is the one that gives everyone nightmares. Now, it is absolutely critical that you understand that AFE happens in 2 distinct phases. Phase 1 is this sudden, violent spasm of the pulmonary arteries. This causes immediate, severe low oxygen levels and right heart failure. Then, just as that seems to maybe be getting better, bam! Phase 2 hits. The left ventricle fails, and a massive DIC kicks in. So in just a matter of minutes, the patient goes from a respiratory crisis into a full-blown cardiac and hematologic catastrophe. This right here is probably the most important clinical pearl I can give you for AFE. The patient might say they feel short of breath, but the very first, most sensitive sign you will see on your monitor is a sudden, sharp, plummeting drop in their oxygen saturation. That pulse oximeter is your best and sometimes your only early warning system. So why do we see signs of RV strain on the EKG in these patients? Well, it goes right back to that first phase. Think about it. That intense pulmonary vasospasm is like someone just put a clamp on the pulmonary artery. The right ventricle is trying to pump against this impossibly high resistance, this brick wall, and it causes it to strain, dilate, and ultimately fail. That massive back pressure is exactly what creates those EKG changes. Look, treatment here is purely supportive, and it is an absolute race against the clock. The priorities are immediate and urgent. High-quality CPR if they arrest. Aggressive circulatory support, I'm talking large-bore IVs and A-line right away. You manage the inevitable DIC with a massive transfusion, and you have to make a fast decision about an emergency delivery. This is the definition of an all-hands-on-deck, everybody-in-the-room-now kind of crisis.
All right. Woof, we have covered a ton of ground. So let's lock in the most important concepts with a final, high-yield, rapid review. These are the absolute must-know points for your exams and for your clinical practice. Okay, let's lock it in fast. PPH from atony, number one cause, first drug is oxytocin. PPH from accreta, you're planning for massive hemorrhage and probably a hysterectomy. DIC, you're looking for low fibrinogen, low platelets, and absolutely no neuraxial anesthesia. Thromboembolism, just think Virchow's triad. And finally, AFE. Remember, it's biphasic, and a sudden drop in SpO2 is your critical first sign.
We'll end on this thought. Knowing the facts is just the first step. The next, and maybe more important step, is mentally rehearsing your response. Run through these scenarios in your head, because when a crisis actually hits, you don't rise to the occasion, you fall back on your level of training. So which one of these scenarios are you going to be rehearsing tonight? Thanks for tuning in.